Okay, great. So if we can just get when he gets back to his office, we'll get the opening slides and then we'll be ready to go.
Okay, so I'm gonna put mine on.
Excellent, thanks.
You see it?
Yep, you're good to go. Okay, so I'm going to go ahead and open the room.
Okay.
Yep, and we're ready to go. Again, if you need anything, just go ahead and ask in the chat. Thanks, everybody. Here we go.
Okay.
Recording in progress.
Good afternoon or good evening, depending where you are. I am Dr. Dionysian. Welcome to the AO North America webinar on complex distal radius fractures. Today we have a great guest and we have a great program for you. Hope you enjoy it. The presenters today are our faculty, Dr. Brent Bamberger from Dayton, Ohio, who runs the orthopedic surgery program there. Is Dr. Neil Harness, a faculty at the Kaiser in Anaheim, also associate clinical professor at the University of California, Irvine. And I'm the moderator, Emil Dionysian, who are also at the Kramer Anaheim Kaiser facility. We also were lucky to have Don Pitts, who's a great hand surgeon, great experience. We'll have his input on this also. So just in terms of disclosures, everybody has disclosed, all conflicts have been resolved. You see what the disclosures are, and none of them are really affecting today's talk. Just in terms of CME credits, AO North America is accredited for CMEs. Today's talk includes about 1.25 AMA Category 1 credit. You can obviously claim only the time that you spend on the webinar. To receive credit for this webinar, a link will be sent to you about 24 hours after the conclusion of the event for evaluation questionnaire. Upon completion of that, you can claim your CME. Now, AO North America is an independent, nonprofit surgical specialty society dedicated to improving care of the musculoskeletal injuries and education, does not endorse or promote any product or services of any commercial nature. Equipment that you may see on the presentation today are for demonstrations and teaching purposes only, and to enhance the learning experience. We're not endorsing any specific product. In terms of Zoom etiquette, all microphones have been muted and the video camera has been turned off. If you have any questions, please use the Q&A box in the Zoom, and the moderator and the presenters, as they're available, will sort the questions. Some of the questions may be answered on the spot, or some of them will be brought up during the question and answer section at the end of the webinar. The use of the chat box is only for the faculty and staff. This webinar is focusing on treatment of distal radius fractures. It will cover various surgical approaches, fixation techniques. This session also will include the post-surgical plan of how to use therapeutic strategies. And also, I'm hoping the participants will gain a comprehensive overview of both operative and non-operative and rehabilitation approach for distal radius fractures. At the end of the sessions, you should be able to at least examine the anatomy of the distal radius fractures, be familiar and identify the treatment options, and have a concept of different approaches for distal radius fracture fixation, and also have a plan and have a good understanding of the post-injury and post-surgical therapeutic approaches. So the planned agenda today is we'll start with the anatomy, concept of diagnosis of distal radius fracture with Dr. Harness. He would also include some of the approaches, especially on the volar aspect of the wrist, how to fix and the pitfalls they have to watch out for. Then we'll have Dr. Bamberger bring up to the other side of the hand, and how do we get to the dorsal wrist, especially if you need to have a more detailed fixation, especially using a standing external or standing fixation. And also, we're going to finish by Dr. Pitts, our therapist, who would show us different techniques of rehabilitation after surgery or after injury of the distal fractures. I will then present some cases. Depending on how long we have time, we may go 2 or 3 cases, and we discuss. We'll have question and answer session, and we'll close about 15 minutes after the hour. Just to be plugged in for the upcoming AO Trauma North America courses, we have a great course coming up in Cincinnati, Ohio, especially the fellows and the chief residents, which is going to be in May 15 to 17. We have a 1-day dedicated hand and wrist fracture management course, which is going to be in Chicago in November 1st. We have other webinars coming up, great webinar about scaphoid non-union in August 20th. And on December 3rd, we'll have a carpal and cubital tunnel syndrome, especially for the failed cases. It's going to be a great webinar. I invite you to all to attend. As far as other online series, we'll have the radial head fracture with a 3-case series with a SAGE presenter, and this will be Dr. Jupiter on May 22nd of this month. September, we have an extensor tendon imbalance around the PIP joint. With the SAGE presenter, Dr. Jerry Huang from Seattle, will be presenting. And also, we have another one in October 16 for slack wrist by Peter Stern as the SAGE of the presenting. Thank you very much. Now I will go into my presentation, and Dr. Harness will be coming in and presenting his anatomy introduction and the volar approach. Dr. Agnes, you can go ahead and continue sharing.
Are we there?
Yep, you can see it.
Looks good.
Perfect. So thanks, Emil, for having me tonight. It's an honor to be able to speak to you guys about distal radius fractures, one of my favorite topics. And I'll be focusing on complex fractures and the volar approach. Don't have any conflicts of interest. So we know distal radius fractures are incredibly common, and they're getting more and more common as the baby boomers age, which is going to be putting a lot of stress on our society as far as the financial aspects of it are concerned. Tonight, just as an overview, I'm going to hit briefly on anatomy and radiographic evaluation, but I'm going to focus mostly on the volar approach, the subtleties of it, and some different thoughts that you can use when looking at the volar approach, avoiding pitfalls and complications. And then when dealing with really complex fractures, I'm going to present you with some ideas and concepts that you can use rather than rules, things you can take home. And when you come into the OR and have a very complex injury, thinking about it in a more systematic way, I think will help. And I'm going to give you some algorithms that you can use. The anatomy of the wrist really, it boils down to 3 columns: the radial, intermediate, and ulnar columns. There's a pedestal, so to speak, that supports the radial and intermediate column. When you have an interarticular fracture, especially one's multifragmentary, you really got to think of these conceptually in the radial column being the radial styloid portion of the fracture, the intermediate column being your lunate facet injury with both dorsal and volar lunate facet, and sometimes interfragmentary cartilage injuries as well as dorsal wall injuries. And then the ulnar column really is your your ulnar head, styloid, and TFCC injuries. Standard radiographic evaluation obviously involves PA lateral obliques. Ultimately, we always talk about inclination and shortening of the radius along with radial height, volar tilt, and articular alignment. These are kind of the basics. But as far as this talk is concerned in dealing with a lot of the issues on the volar side of the wrist, it's good to know the 10-degree lateral tilt view. It's really the one that gives you the best view of the lunate and where it is in relationship to the facet. The lunate should really be bisected by a line drawn along the volar cortex of the radius on this type of lateral view. And then you can actually get a good measurement of the teardrop angle, which is about 70 degrees off that axis. Standard radiographs are important, but often fail to depict important characteristics of injuries, especially more complex fractures. And that's when two-dimensional CTs can come into play, but even those can be difficult to evaluate. Fracture fragments can move in and out of the frames of the image and be difficult to assess. So that's where in 2006 we published an article looking at this and found that the addition of a 3D CT scan can improve the reliability of the observations made by various individual raters, and two-dimensional and three-dimensional CT scans, when combined, can change the way you approach fractures and also the types of fixation you might choose. So I think 3D scans in complex distal radius fractures can be invaluable. Here's just an example. This might look like a very minor isolated lunate facet fracture. The arrows are kind of pointing out the fracture line, which may even be difficult for you to see on the screen. But after two-dimensional and three-dimensional CT scans were obtained, you can see there's quite a bit of displacement of the lunate facet, much more than you would suspect on a plain film alone, and this needs surgery. So it really might go from being a non-operative case to an operative case just based on the scan alone. Classification systems can vary quite a bit on their goals. They all have their merit. The AO comprehensive system is really more of a research tool. I typically like to use the Fernandez classification because it's more of a mechanistic injury classification system. Type 1 being bending injuries or your typical Colles fracture. Type 2 is your shearing injuries or your Barton's fractures. Type 3, your compression or interarticular multifragmentary fractures. And then type 4 are your fracture dislocations with very small distal marginal fractures. And then type 5 is high velocity combined injuries. When I talk to patients about whether they need surgery or not, I still like to use the LaFontaine criteria in describing the fracture and the severity of the fracture. That goes without saying that, dorsal angulation greater than 20 degrees, dorsal comminution, all important. Interarticular involvement, associated ulnar styloid fracture, age greater than 60. When you have three or more of these factors, you're unlikely to hold that fracture in alignment in a cast. But more recently, a paper compared the LaFontaine criteria to a very simple lateral view hook test. So if you can interdigitate that strong volar cortex on a lateral view, that actually was the strongest predictor of the final volar tilt and overall carpal alignment compared to any of the LaFontaine criteria. When you look at the AOS guidelines, most recent guidelines for patients 65 years in age and older, there's very strong evidence that non-operative treatment should be used as a first line and that surgical treatment may not be necessary. Now, again, you still have to look at the physiologic age of your patients in order to make that final decision because it can vary quite a bit based on how active people are. Patients under 65, they found moderate evidence that supported surgery when you had more than 2 millimeters of step off, radial shortening more than 3 millimeters, dorsal tilt more than 10 degrees from neutral. And when they looked at fixation, there was strong evidence that all methods of fixation led to similar outcomes, and that volar plating, while it's the most popular, really only allowed earlier return to activities at 3 months. But after that, all methods seemed to get to the same final ending place. So surgical treatment principles really boil down to these. If you have an intra-articular fracture, you have to get a good reduction. You have to get a perfect alignment to have a good outcome. You want to restore the volar tilt and ulnar variance, and less importantly, the radial inclination. Restoration of coronal alignment has become more and more important and looked at more recently. In order to restore DREJ stability, you have to restore that coronal alignment. So you want to achieve stable reduction and fixation with whatever method you choose in order to allow for early motion, especially early finger motion. Now, the surgical treatments are basically percutaneous techniques, external fixation, and internal fixation. And even percutaneous techniques are still valuable. This is an X-ray. It actually was a case I did as a resident with Jesse Jupiter probably 25 years ago. This is Norian bone cement with a couple pins, and this patient did fantastic. And so you don't necessarily have to have a volar plate to have a good result. External fixation is very, very valuable in fractures with the open fractures with extensive soft tissue injury or contamination. They can be a good temporizing measure in polytrauma, and also it can be important in the setting of a wound infection. This is just a simple bridging external fixator pattern. Key is you want to avoid over distraction in order to prevent finger stiffness, CRPS, and carpal tunnel syndrome. And ultimately, patients do not like external fixators, so they've really lost support in basic injuries. They can be cumbersome, they can inhibit motion and rehab, and you almost always are dealing with pin tract infections. So dorsal approach I won't hit on much because I know that we're going to talk about that later, but the reason the dorsal approach got a bad name is because of tendon irritation, tendon injury, and problems in the late 1990s. And so really the dorsal approach gave ORIF a bad name, but then along came volar plates. Our savior. So it's one of the most important innovations in hand surgery in the past couple decades, and with improved implants and designs, it's really made ORIF reproducible, and even in the setting of more complex injuries or patients with osteoporosis. But I would say that volar plates cannot be used for everything, and a volar approach cannot be used for everything. I will focus on the volar approach, but I'm the first to admit you have to make a decision going into the surgery that you may not be able to handle it all through one incision, and that you may need to make a decision to go dorsal. Fragment-specific fixation or column-specific fixation is a great tool. Now, volar plates and fragment-specific fixation, those are obviously competing philosophies, but I think we can reach common ground when we're talking about these two methods, and you can actually use them in conjunction. So the take-home point is no one method of surgical treatment is superior to another. But why is volar plating so popular? Well, the volar cortex of the radius is the most stout bone in the wrist. The dorsal cortex is much thinner and fragmented. And so when you're trying to reduce a fracture, having that thick volar cortex, which you can interdigitate, can really help gain your reduction and maintain the reduction much more easily than through a dorsal approach. You also have a much thicker soft tissue envelope to put over your plate, the peroneal quadratus, and also there's much more space between the plate and the flexor tendons. Now, fixed angle locking plates, incredibly common. We all probably know exactly what we're talking about here, but there's usually two rows of screws that have a fixed angle that are set, and that fixed angle you have to get a perfect reduction in order to use a fixed angle locking plate. If you don't have a perfect reduction or you have residual dorsal angulation, there's certainly a higher likelihood that you might have an intra-articular screw placement or some sort of errant screw dorsally. That's where variable angle locking comes in. This gives you a little bit more versatility in dealing with more complex fractures and placing your screws in particular positions where you want them. The volar rim fixation plates are available for very distal marginal fractures, even hook plate extensions to help with small volar lunate fracture fragments. More recently, carbon peak type volar plates have become available, which are unique, but I'm not sure how helpful they really are. You can follow your fracture and see the healing of the fracture more easily. More importantly, it might be a good tool to use in patients who you might think need an MRI down the line. But other than that, I haven't seen it take off as far as popularity over standard volar plates. The volar radial approach is an incision, or basically an incision along the FCR. You obviously have to isolate the radial artery and protect it, and then you mobilize the FCR ulnarly, protecting the median nerve. It's important to know that the palmar-cutaneous branch of the median nerve does travel through the FCR tendon sheath in about 5.5% of patients, so it's something to look out for. In the bottom right-hand corner, you can see the picture. In the base of the FCR tendon sheath is the palmar-cutaneous branch. So you want to clear the bursal tissues between the FDP and the peroneal quadratus. You release the peroneal quadratus with a longitudinal incision, and then a transverse incision at the level of the the distal radius articular surface. You don't want to go too distal, though. You want to stay just proximal to the watershed line, which is really the margin of detachment of the strong volar ligaments of the wrist. Sometimes the reduction isn't easy to achieve because you're dealing with a nascent malunion or a very shortened fracture, and releasing the brachioradialis can help you mobilize the radial styloid. Release of the dorsal periosteum and removal of the early healing callus and hematoma can be helpful, and this can be done by pronating the radial shaft completely out of the fracture and cleaning that out. If all else fails, and you're really having trouble gaining reduction, you can use the plate as a reduction tool. You can place the plate distally using guide wires to align the plate, place your screws distally first, and then use the plate as a lever arm to push the fracture back up into alignment, fixing your plate to the volar cortex of the radius after that. When you have a lot of metaphyseal comminution, sometimes it can be hard to regain length. So sometimes you can use a small or mini external fixator to realign the wrist and then place your plate. In certain situations, you could even use a laminar spreader. This is an example of using a post, a screw placed proximal to the plate, and then using the laminar spreader to push the fracture distally. You have to attach the plate to the distal fragment first, just like the other example, and then you can use your laminar spreader to gain length and then place a couple screws in the shaft to hold position. Coronal restoration can be achieved through another distal fragment fixation first technique. If you place the plate distally first with a couple screws and then place a screw proximally as a kind of a rotational or pivot point, you can then rotate your distal fragment into position and correct that coronal alignment using a crab claw reduction forceps. And this is an example of that. Here's the volar ulnar corner alignment restored. What is the complication rate with volar plating? Well, it's actually fairly low. In a recent report last fall, they reported 12% complication rate. Again, a lot of those were minor complications. Even hardware-related complications were pretty rare, but intra-articular screw placement, prominent plate placement with synovitis, dorsal screw penetration, those are all very, very rare, but still can be seen with volar plating. Some of the pitfalls you want to avoid are dorsal collapse. Obviously there are locking screws, but locking screws can fail. Bone can cut through locking screws. The locking screws might maintain their position, but because you've placed the screws too proximally, the bone can sink. So loss of length can be a problem. You can errantly place screws in the joint, which I alluded to earlier. Extensor tendon ruptures are still a problem, even with volar plating, and then flexor tendon ruptures. So how to prevent dorsal collapse? Well, you want to get the plate as distal as possible, but not too distal. You want to get the screws right under that strong subchondral bone in order to prevent the fracture from sinking. But at the same time, that places a fixed angled plate in a position where you might erroneously place a screw in the joint. It can also result in a plate being too prominent volarly, causes tendon irritation. So if you're having trouble gaining stability with a volar plate alone, you might consider using a radial column plate to add to the fixation. You have to really understand the fracture pattern going into the surgery so you have the appropriate plates available to use when you're in there. So to avoid placing a screw in the joint, one of my former co-residents, Max Sung, published a paper in 2008 looking at the different views you can achieve with a fluoroscopy intraoperatively, and found that the 11-degree PA view was the best view in order to look at all the screws and to accurately predict whether you've penetrated the joint. If you want to look specifically at the radial styloid, a 30-degree lateral view is best, and the lunate facet, a 10-degree lateral view. Extensor tendon ruptures, I just talked a little bit about. They're a problem. If you place a screw through and out the back of the distal radius, you're at risk. And Lister's tubercle is part of the problem. Lister's tubercle can basically obscure the view of a long screw that's placed within the third compartment. A cadaver study looked at the variation of Lister's tubercle depth and found that it varied between 4 and 10 millimeters. So quite a variation that can happen. So you really need to downsize your screws in the central portion of the plate. And I typically would downsize them by about 25 to 30% in order to prevent this problem. The other thing you can do is take a dorsal tangential view. Also, I think it's commonly called the Hoya view, where you place your forearm on the fluoroscopy at a 15-degree angle and then maximally flex the wrist. And this can give you a really good view of the dorsal cortex and show you if you have any screws that are penetrating. FPL ruptures are still common, even though it's well known that you have to keep your plate proximal to the watershed line. This is just a good example of the design of a typical volar plate and where it should sit proximal to that point. Again, Max Sung in 2011 published in JVJS a really good article looking at lateral views and found that if you place your plate in a position where the red line here is crossing through the plate, so too prominent volarly, you're at higher risk of tendon rupture. So a lateral view, if the volar lip of the lunate facet is beneath the plate or more dorsal than the plate, you're probably going to have a problem. So that's a very important radiographic finding. Moving on to some more complex fractures that you treat through a volar approach, the Fernandez 2 shearing injuries. Look out for volar Barton's fractures with separate scaphoid and lunate facet fragments. This is just an example of an old pie plate from the early 2000s capturing a multi-fragmentary volar shearing injury. But then 2 weeks later, the patient came back and the whole carpus had subluxed with that volar lunate facet fragment up and over the plate. And this leads to deformity, dysfunction, and pain. And I published a paper in 2004 looking at just this. We found, this was a problem that nobody had really talked about before. And the question is, why is this happening? And it's really due to the fact that the volar lunate facet has a very unique anatomy in the corner of the wrist. And it's very difficult to judge the size and morphology of this fragment. It's very difficult to get to the fragment from a standard volar Henry approach. And ultimately, if you look at the anatomy, the lunate facet fractures that we see in practice encompass about 16% of the articular portion, and it projects out or is cantilevered out over the volar cortex of the radius. So it's a very unusual portion of the wrist. If you look at the axial view, the cortex slopes away from where you're working. It slopes more dorsal and ulnar. So again, getting fixation is a challenge. There's a tremendous amount of force that's applied to this portion of the wrist. And the ligamentous attachments that are seen here also produce a significant amount of force on that fragment and make it more likely to displace. We published another paper in 2013 looking at failures with appropriately placed plates and screws. So more modern plates that have a volar ulnar extension placed appropriately with what we thought were appropriate screws. There was still a 28% loss of fixation and volar subluxation. And the key finding was that on lateral view, if you measure from the tip of the lunate facet to the base of the fracture, if it's less than 15 millimeters in length, you have a higher likelihood of loss of fixation. There are also variants. It doesn't have to be just a partial articular fracture. There are C-type fractures that have lunate facet fracture fragments, and there are isolated lunate facet fracture fragments, both of which have been shown to lose fixation after appropriate management. So what do you do? Well, part of it is just getting to the fragment. You have to choose an approach that will allow you to get good visualization and allow you to put hardware in. And part of that is using a more central approach or perhaps a more ulnarly based approach in the setting of an isolated volar lunate facet fracture, going between the FCU and the ulnar neurovascular bundle and the flexor tendons and the median nerve on the other side. Even sometimes working through a radial window and a ulnar window. So kind of working on either side of the flexor tendons can help you out. Here's a volar radial window. You can see the lunate facet fracture fragment. Clearly not going to adequately capture this with a volar plate. Now, looking at it through the ulnar window, I've basically put a couple pins to demarcate the edges of the fractured fragment, and it's about 1 centimeter long. So it's definitely under that 15 millimeter rule, and that plate is definitely not going to capture it. So the other way to get to it without making a more central approach is using a standard Henry approach, but doing an extension, otherwise known as an extended flexor carpi radialis approach. And this was popularized by Orbe in 2001. It involves the detachment of the FCR to the trapezial ridge and more significant mobilization of it distally to allow you to retract it. This was an a cadaver study done by Orbe last year, and it's kind of a nice study. It shows that on the bottom right, the Henry approach, you can see that purple mark with a little blue circle. That's the distal and most distal and most ulnar extent you can get hardware in a standard Henry approach. Now, looking at the extended FCR approach, you can see that red circle shows you the pen mark. They're all the way at the volar ulnar corner, and they're able to get fixation in that far distal and ulnar. So a big difference, and it really can save you. So what are the fixation options? You've gotten to your fragment. It's really small. It's difficult to fix. Well, there's a number of different things you can do. It doesn't have to be fancy. There are any number of fixation techniques you can do with hardware that's available in most ORs. Figure of 8 tension band techniques, headless screws, K-wires placed through the fracture fragment and then bent down and captured with the volar plate is a nice technique. There are fragment-specific implants and even hook plates that you can extend from the volar plate. And one of the things that I've noticed in treating a lot of these over the years, even the ones that have failed and have been sent to me, is that the lunate facet really has 3 basic patterns: triangular, boomerang, and more trapezoidal. And if you recognize the shape, it really can guide treatment. And this is just an example, kind of what these would look like intraoperatively, and you're just not going to capture these with a standard volar plate. This is an example of an older gentleman with a triangular shaped volar fragment, and I used a standard volar plate. I used the screw on the ulnar side as a post, and I used a dental wire around it to create a tension band effect with a couple K-wires. And this was more than adequate, healed, maintained position, and didn't require any special hardware. Another example of a boomerang-shaped fracture in a C-type fracture. Here it is, very small fragment, hard to get to, hard to fix. And with this, I ended up using that volar ulnar window, and you can see I placed a couple K-wires. Those are actually K-wires for headless screws. And I just put a couple headless screws in the fragment to maintain the position, and that worked out fine. In a more trapezoidal shaped fracture fragment, you may need to use headless screws as well. This is an example. This is kind of jumping ahead. I did go dorsal on this case, but so we'll just forget about this one. Now, for Fernandez 3 compression articular fractures, you can still do these from a volar approach, but it gets more and more challenging if you're just going to use a volar approach. You're dealing with small, little, tiny fragments. We used to call them chiclets. Fragment-specific fixation is really something you're going to have to probably utilize. And also, when you're dealing with these, I like to think of these through an algorithmic approach for fixation. So when you're in there, you want to, in most cases, start with the ulnar column first. Reconstruct the ulnar column to the pedestal, and you may still be able to use a volar plate alone, but you might need to start thinking about fragment-specific fixation. Think about an extended FCR approach or a more volar ulnar approach. The dorsal ulnar corner can be fixed from a volar approach, but it gets really, really challenging the smaller and thinner that fragment is, and you may need to start thinking about going dorsal. Interarticular fragments, start thinking about bone graft substitute or even cancellous bone graft to help support those fragments, and other approaches may be needed. Dorsal wall fixation, obviously you're going to have to go dorsal. Then move on to the radial column. You'll want to reconstruct the radial column to the pedestal, and you can buttress that against your now reconstructed ulnar column. You can still use a volar plate. So if you started with a volar plate to get your ulnar column fixed, you can add to that. But you may need to consider a radial column plate. You may need to consider bone graft or bone graft substitute if you have a lot of comminution of the radial styloid. And ultimately, I think the hardest to fix from the volar approach is that dorsal ulnar corner. This diagram makes it look like it's this huge fragment, but they never are. These little die punch fracture fragments are challenging, and the recent papers show that these on average are less than 5 millimeters in depth and almost always make up less than 24% of the volar dorsal width of the lunate facet. So you're going to have to use long screws. Again, it's going to be a catch-22 because it could put your screws dorsal into the soft tissues and you might have a tendon issue. Here's an example of one. This is super thin. On the CT scan, you can see that it's very challenging to fix this. You can use a special clamp to push the fragment up to your intact volar cortex and try to put a screw through it, but it may be challenging. This is an example of a C-type fracture where this is a quick example of using a volar plate. But I went with a volar plate initially, had trouble getting the radial buttress effect, so I ended up adding the radial column plate. And this is done through the volar approach, but you have to release the first compartment. You have to mobilize those tendons. You have to look out for your superficial sensory branches, release the brachioradialis. Once you're done putting the radial column plate on, you'll want to put the retinaculum over it to protect your soft tissues. This is just an example of one I did years ago. And with that, I think the take-home messages I want to reiterate: pre-op planning with a 2-dimensional or 3-dimensional CT scan can be really valuable, especially in these more complex fractures. Your approach, obviously a volar approach is a fantastic approach, but you might need to modify it in order to get to more complex volar ulnar corner fractures, or even mobilizing the fracture to gain access to the radial column. The reduction, if you're having trouble, use your plate as a reduction tool. It can be really invaluable, and I've shown a few examples of that. Judicious use of the fluoroscopy intraoperatively to assess your plate and screw position is critical to avoid complications. There are also going to be alternative options to fix small fragments. Think about using fragment-specific fixation. When you get to a point where you have multiple fragments to fix, think about using an algorithmic approach as I've described. And if all else fails, go dorsal. Thank you.
All right. Thank you very much. That was a great talk, especially, very comprehensive, including the volar ulnar corner. It was the best talk I've ever heard on that. And so now we're going to switch back into the dorsal side, and especially considering the sometimes use of the spanning plate. So we have Brent Bamberger from Ohio who's going to kind of clue us in the dorsal side.
That talk was amazing. I think we could just go home. We don't really need mine. That was unbelievable. I'm not going to touch on that dorsal ulnar. I think that's with the fragment specific, it actually addresses it. If you can't get it from the volar side, you go dorsal. And appreciate Dr. Harnes's. We're going to talk mostly about the spanning plate. So you got the typical one. This is not asking for a question. This is your brain working and trying to figure out what are you going to do with this. We love pickleball now. It used to be inline skating and everything else, but it always keeps us in business. Why not try an external fixator? I grew up on an external fixator. This was how we used to take care of most of them. We discussed the possibilities of making non-spanning external fixators. It's based on the same theory of ligamentaxis, done a lot to protect soft tissue. AO is basically taking care of soft tissue injuries that occasionally have fractures involved. But they weren't perfect. You had limited control of articular fragments. You had pinstripe infections, and everybody had their little trick, whether it was leave them alone, push them down, use peroxide, but it was always a little problem. And then if you were in the colder areas, not in California, but if you're in the colder areas, it's difficult to put a coat on when you have these external fixtures. Principles, though, can't get away from principles. The bottom line is, if you go back to the stuff about X fixes around the or anywhere. There's a little activity used to do at all the AO courses as far as bringing people closer together, putting their arms closer to the chest, making more stability. So essentially, if you can get that rod closer to the bone, it's going to be more stable. Another principle, and won't have it completely, but by John Agee, was a whole palmar displacement of the carpus and being able to kick that articular surface back. We lose a little of that in some of these, but it's a great thing to go back and look at this history. Volar locking plates, we just heard fantastic talk on it, all the different things you can do. Sometimes they don't work for everything. As I said, you try one way, you can always go to somewhere else. The other alternatives with Bob Medoff, and there's plenty of good papers by Peter Ree et al. Looking at the different ways of using fragment specific. So dorsal spanning plates. These started, it's interesting, we'll talk a little bit about history, but it's been around a while. They're basically just trying to get an internal-external fixator. The real interesting thing about it is it's more for higher trauma, soft tissue injuries. It maintains length. You don't have to worry about the external hardware if you're dealing with an ICU. Sometimes, osteoporotic patients, you may have to use this as belts and suspenders. So it's kind of high trauma and bad bone. So where does the history come from? From the Motor City. Actually, the original one they did was in 1988. The paper down on the bottom right is in the techniques of hand upper extremity. That was 300 cases that they produced. But there was plenty of papers before that looking at the original. Now, their original was going through the fourth compartment. There's modifications since then, and we'll talk about it. But they're looking at distraction plating. The other thing is, I grew up through fellowship at Tampa in the early 90s. We were using 3-5 plates for fusions, and we were getting all these metacarpal fractures. So we were using those 3-5 screws. So things have evolved since then. So what are the biomechanics? As I said, it works as an external fixator. You can look at some of the literature of whether it works as a tension band. I'm more convinced it's ligament ataxis and sort of salvaging your soft tissues to get bone stable. It's a sharing device. I'll be interested to hear what our therapist talks about it, because it's difficult to get range of motion with these because their wrist is not in an extended position. But they do seem to work well, but we need a skilled therapist to work with us. When do you use it? As I said, highly comminuted, poor bone, metaphyseal, where you're trying to bridge. I mean, a great talk at Ohio State just recently, just about bridge plating all over the place, whether that's PIP, whether that's elbow. So there are ways of using internal, external fixators to get some of this stability in our bony construct. And it's a temporary bridge. It's kind of, damage control ortho. Now, so looking at these approaches, pulling right out of AO, you know where you're going to go if you're going to go on the second metacarpal. You can also go down and put it over the third metacarpal. So you're getting in, you can either open up EPL and drop in. It's interesting, again, showing age. Since you're over 65, they talk badly about you, as we heard in the last talk. But we used to do the dorsal approach for almost everything until the volar approach came out, and that was 2000. Those patents for Medoff and Orbe were all in 2000, so it hasn't been around that long, but it's now the established way of doing it. So people don't know how to do the dorsal. It's easy through the EPL, lifting up fourth compartment and second compartment, and actually being able to look in at the joint if you have to go that way. You can do a smaller approach when you're just trying to get down to put a spanning plate on the second metacarpal. And then how do you actually do this whole thing? Well, essentially what you're doing is using a freer, getting that second compartment if you're going to use the second metacarpal as where you're putting your plate, and then kind of teasing things up, almost like an upside down pilon or an upside down plateau. You can get temporary fixation. And this is actually a wrist fusion plate. So, back in the day, you use what you could to get across it and to span it. The newer ones, obviously, are some of the ones seen on the right, and being able to shift them percutaneously and lock everything in. So the plates, these are the original ones come out that were a little different, and they've modified over the years, but you're just trying to get some type of traction and not have to look at, as was stated before, not have to look at the little chiclets, because you're not going to put those chiclets back together. So why not use a fixator? We are using a fixator. We're just putting it closer to the bone. When can they weight bear? It's interesting. There's some papers, and I couldn't find one of them, but it talks about that actually a good volar plate, you can weight bear on it. But we're not talking about good bone, and we're not talking about simple fractures. So the spanning plate does help you for a little bit of weight bearing. Which metacarpal do you put on? The original back in the early 90s was on the third metacarpal. Now some of the slicker ways are on the second. And what are you trying to get? And can you do other treatments, not just a spanning plate? So the advantage are it's more rigid. You're getting real close to bone. You're protecting soft tissue. You can hold some of these dorsal buttress. You can actually use this sometimes to maintain the hand of the forearm so you don't have that volar escape sometimes. So is it strong enough for weight bearing? I mean, you can definitely get weight bearing with a walker right away. You can do it with an ORAF also with a volar plate. You just have to watch yourself of what other things you need to use. So can you weight bear with crutches? That's where the difficulty is. I can tell you that's a lot of force on an osteoporotic bone to if you're just counting on that second or third metacarpal to do it. So you kind of have to watch for that. So platform crutches, again, reaching out to the therapist and a previous degree of mine is you can use platform crutches, you can use platform walkers and get these people up and moving very quickly. So which metacarpal? Second one, supposedly a more direct approach. It's a little easier approach if you're trying to do just an X-fix, since we were doing everything on the radial side, mostly on the radial side, with all except some pinning through the ulna, which is a different study. Trying to get more palmar displacement of the carpus. And this is where I couldn't find it, but just anecdotally, it looks like on the, just by the shape of the radius, as we saw before, if you put this on the second metacarpal and slide it down the radial side, you actually may get a little more palmar displacement. If you're on over the third metacarpal and you're over that side of the radius, you may be a little distracted. People have talked about putting washers underneath to make sure you're pushing down the surface. So little technical tips is just making sure you're not using this to take care of everything and being hypercritical of your post-op x-rays. There's probably less tendon risk because you don't have as much adhesions. If you look at the original papers by Burke and Singer, they were doing tenolysis when they took those things out. They were putting them through the fourth compartment. Now I think if you're on the third, they're shifting it just to the radial side of the fourth compartment. Again, the third may be a better construct, maybe better for the lunate fossa, but maybe not better on volar to dorsal. You got risks. I mean, once you have a plate, you've got problems with tendons going across them. Difficulties, again, for the therapist that we'll hear next. So there is a paper. If you're hard pressed on making a decision between second and third, the third gives you a little more stability. For some reason, I like to use the third when I'm doing with the fracture dislocation, and that's sort of in the line of these distal radiuses. They're not just the comminuted distal radius; they're the actual dislocations that occur. So either one is going to give you adequate reduction and pull it over. There's anecdotally some talk about trying to get reduction of get more radial tilt by putting on the second metacarpal. Technique-wise, I usually put non-locking screws distal and proximal and then be able to adjust things before placing locking screws afterwards. So you have a little bit of fiddle factor, almost like you're like the reduction that Dr. Harness talked about by putting screws distally and then putting an axis screw and being able to rotate around. You can do the same thing, but on a longer lever arm. You get adequate alignment with these severely comminuted ones. Is it absolutely perfect? No, but the question is, what do you need? Is it worth all the soft tissue dissection to get every little chicklet in a 67, 68-year-old or 80-year-old, or is it better to get a little bit of spanning plate, get their fingers moving right away and move forward? It's all dependent on the type of fracture that we have. So we augment this. This is bringing history back around. There's a lot of papers when we were talking about X-fixes. Is should you do a volar plate in an X-fix? Should you use K-wires in X-fix? Should you use Kapanji pinning and X-fix? All some of the older techniques, and it all proved out that you can. So what does it actually do? It actually helps the articular surface. So the one thing that this doesn't do as well is fix the articular surface. So you can get the articular surface lined up, a la Diego Fernandez in the past with all the, making sure they had alignment with K-wires and then be able to hold things out. It's the same thing as the X-fixes and now internal spanning plate. You can use volar plates also, kind of buttressing things up, using all the principles we know and almost flipping this thing upside down and making it a plateau where you're doing buttress plating underneath it and then almost putting an X-fix across the knee. So just, again, using AO principles to use these different type of mechanisms. So go back to what was done with this. It was a spanning plate. The amount of comminution, even though she's 56, looking at her metacarpal, she's a little osteopenic. So the thought was the soft tissues weren't happy. So it was to use this. Now, as I said, it's not anatomically perfect. The articular surface looks good on the lateral, little step off on the radial side, but overall she's back at pickleball. So basically, dorsal spanning plate's a reliable solution to get rigid fixation without the internal pin or external pins. You're using polytrauma, the severe one with again all the chiclets. If you're unable to fix them, it's strong enough to start finger and elbow motion. I'm a big proponent of making a good fist afterwards and full supination and pronation, no matter what fixation. But you can't use it for every single thing, as we heard in the previous talk. It's an augment that you need to have in your armamentarium. Thank you very much.
This was great. Treatise on the spanning plates. I feel much more comfortable myself putting the spanning plates now. Obviously, all of these injuries will cause a lot of stiffness with the hand, and so therapy is a key part of post-reduction or post-surgical. So we have a great pits here with a great therapist who kind of give us some clues about how to proceed after the surgery or after the fracture to get better results. Greg, you're up.
Thank you very much. Two tremendous talks. I really appreciate the opportunity, and we will. All right. So just a little bit of background. I teach for the U.S. Army, battlefield trauma, disclosures. Kentucky has Toyota basketball, bourbon, and horses. That's where I'm from. My hometown has the hand as a symbol. I'm a CEO of 6 clinics. I own the clinics, have 90 staff, 42 therapists, been in private practice for 27 years. My mentors, Peter Murray, Ralph Herms, Dr. Reardon. I was part of the Reardon Hand group for 10 years. Distal radius fractures, they pose a nice challenge for therapists because you have to combine a lot of different skills to get a good outcome. And I was raised up with the external fixes, as was talked earlier, and we actually had good results. But the result from the X-fix was a lot of stiffness that new therapists nowadays are not used to seeing because they're spoiled by the plates. Big differences. We deal with a lot of psychosocial components to distal radius fractures. It's a long-term injury. It takes at least a year and a half to get over and completely see your results. We look at the hierarchical functional return and use it as a means to treat and implement ergonomic implementations for ADLs to maximize the results. Treatment approach. We deal a lot with wound care, scar management, patient education, treatment of pitfalls before they occur, ADL training, motor re-education, and getting them back to work and work simulation. We have to know the stages of healing very well. All types of tissues. We're dealing with bone, all the soft tissue envelopes that the surgeons go in and fix the bone. And we say we treat distal radius fracture, but actually we're treating all the soft tissue components around the bone fracture. And so that's really can become very complicated, and it takes a lot of time and energy to get a good outcome. The pitfalls: you can have atrophy from disuse, cortical change. The brain, the hand makes up 1/3 of the brain, so you can have a lot of changes that occur from disuse. The doctors both talked about digital motion, which I totally agree. The unskilled therapist will focus on the wrist and not the fingers, and the fingers are the magic to getting a good outcome. You really got to understand intrinsic and extrinsic tightness to be able to fix it and be able to do joint molds early in the rehab process, in the acute care phase, not waiting until they get stiff, and treat the pain reflex before it occurs. Evaluations. We do all kinds of evaluations to stack data to help the surgeons make decisions. But the big one I want to talk about first is the quick dash. And we did a huge study on this. And if you use this in your clinic and have your therapies, you use it trending, you can predict your outcomes. If a dash scores above 60 at the first visit, a red flag should go off in your mind. If the score does not change by 20 points after the fourth visit of therapy, a red flag should go off. If after the 8th visit, the score is still above 50, the red flag should go off. They're missing. They need to do more work, more time in therapy. We have a large database. We've published this several times, and it helps you predict outcomes for a variety of different injuries, to include distal radius fractures, to predict the outcomes. So phase 1, we remove bandages for the doctors. I see them day 3 to day 5. We start wound care right away. I call if they have any type of infection issues. We educate the patient on risk factors, what they can and can't do. We promote early safety, edema control, scar management, and start motor re-education. We start it through motion, and we have to move the hand, and we move through basic 5 hand postures, which maximizes tendon glide and differential tendon glide for all the different tendons that cross the wrist. Extremely important for edema control and to avoid adhesions. We start joint mobilization extremely early. We distract the digits, the carpus, and we do joint mobs grade 1 and grade 2 for all the joints to stop the intra-articular adhesions from occurring. Dr. Brand talked a lot about potential function is based upon force, work, and power. In the acute care phase, we work on force, maturation phase, work, and the last phase, power. Edema is our enemy. It's scar and evolution. And without moving and having digital mobility, then you will fail the patient and fail the doctor if we don't get these patients moving early, particularly their digits. The digits help push the fluid out of the hand. There's a design flaw in the hand. There's about 4 to 5 times more blood flow into the hand than there is venous outflow. And the way you get rid of the edema is through motion, compression, elevation, and you got to start it right away. And if you can't start it right away, you get in trouble. So it's very, very important. Edema creates fabric bias, which puts stress on the connective tissue, which limits the amount of motion that you have. So edema is a big, big enemy that we have. How do we control edema? We put TENS units on the median nerve distribution, which controls 85% of the autonomic fibers. And this actually helps control the swelling, the vasomotor reaction. We also put the TENS unit on the PIN nerve, which innervates the joint capsule, which controls joint pain. We start this day 1. We treat everybody like they have CRPS, therefore we don't have CRPS very often. We look at active range of motion and passive range of motion, evaluating the intrinsics. If we let the lumbricals get tight, they shut down the profundus, and we don't have a good functional fist, we can't put the swelling out of the hand. We look at extrinsic tightness, both volar compartment length. This is a very important measurement to take as a doctor and as a therapist, because you want to look at not joint motion, but actually joint and tendon motion together. So you can actually objectively evaluate the extrinsic tightness of the flexors and of the extensors. Extremely important. We've noticed the normal is around 60, and the closer you get to that normal, the less pain, the less swelling, and the more function. Scar. Edema is scar and evolution, and if you can treat it through vibration and silicone, you can take care of the cutaneous pain reflex that occurs, which will keep them out of your doctor's office for more pain meds. We also use differential scar massage to break up the scar over top of the plates to allow the hand to move better and to increase the functional capacity of the hand. We also look at nerve glides and nerve gliding. When people fall on the outstretched hand and have complex injuries, they oftentimes hurt the entire kinetic chain. And we look at the nerve function from scalenes all the way down to the tip of the finger. We start nerve gliding right away in the clinic. We look at motor control, and it's very important to understand that occupations are very powerful for motor reeducation to establish the appropriate motor type, the appropriate sequence of firing, the force regulation, to increase self-esteem, increase capacity for function. These people are scared and they need to be able to use their hands, and the best way you can gain that is through functional activities. And there's a variety of different things we do: biofeedback, all types of light level activities, early phase of rehab to get their confidence back. ADLs, simple dexterity tasks, get this hand moving so they don't get stuck and get stiff. Not just exercise alone. We also do scapular stabilization early with every distal radius fracture, actually every human. If you got a hangnail or a distal radius fracture, you're going to get scapular stabilization because it's the key to controlling edema and controlling nerve pain. We also start stress loading programs extremely early. This is a late phase, a stage 2 or 6 weeks plus, but you can actually set a patient down and start low-level stress loading with a ball and TENS unit on at day 3 to day 5, just as long as you start stressing the upper extremity through a closed chain activity. We also treat with paraffin to soften scar tissue so it'll move, and we use fluidotherapy to desensitize the skin and desensitize the scar. Level 2, we start strengthening programs, which is very, very important for IEDL and heavier activities, particularly work tasks. We do weight bearing. This is very, very important. I think this is more accurate for functional outcomes prediction than is grip strength. And we do weight bearing. We just take a simple weight scale and we mark it with a piece of tape with an X on it. And we put the middle finger and we check right versus left. It's not exact science because this is a scale from Walmart, but actually it does give you an idea of where their weight bearing is located. Enabling strengthening activities, we start out with isometric strengthening first. There's a lot of studies that show that isometric strengthening actually controls pain, but at the same time it doesn't create a lot of shear forces and allows you to start strengthening early. We start this at around a 6-week point once the doctor says that the fracture is doing well and it's healed. We start multitasking where we do strength activities and dexterity activities at the same time to increase the brain's capacity as well as the hand's capacity for function. If you have impaction syndrome and you just start showing up at the 6 to 8 week point, we will strengthen with the hand in supination versus in pronation, because in supination the radius elongates and takes pressure off the ulnar side of the wrist, and so therefore we decrease stress on that side of the wrist and increase our capacity to do functional activities of strengthening. We also do graded motor imagery, particularly for people that have early signs of autonomic flare. We will start them very early in the rehab process, and we actually start, if we have people who have stiff hands, we'll start muscle stem very early with profundus, because if profundus sits right next to the fracture site, we can stem profundus deep and pull them through across the plates so they don't get stuck. And we start this as week 3. We also can do functional strengthening. This is an example of we have a puzzle attached to some bricks and they have to stack to get their strength going with different types of hand postures. We also do all types of functional activities like mechanics, plumbing type simulation, sanding and crafts, anything that we can to get the hand working and can get the hand moving with the brain. Here's an example of a guy using a sander with a gripper on it. Here's a guy that's staining a board with a weight attached to it. We also do this as a good example of muscle reeducation. I've done your face.
Okay, that's
you
awesome.
doing it. So we have an iPad attached to a built-in handles. We're using scapular stabilization behind here, so we're pushing the scapula into retraction. At the same time, she's doing a functional activity for stability of the wrist and motor reeducation. Here's actually an orthopedic surgeon that fell off a ladder and broke his wrist, and he's getting back to learning and reestablishing motor skills for surgery. He's a general orthopedic surgeon, does hips and knees. Here's a ICU PICU doc, fell off a plane coming out of Ecuador doing missionary work, broke his wrist, and he works in the NICU. But he's working on reestablishing force regulation to be able to intubate patients. Final phase of rehab is our torque phase, where you're doing overhead activities, dynamic tool use, on and road deviation, pronation, supination. This is the hardest type of tasks that the wrist has to do. It's the last to come back and the first to leave. Not everybody has to get to this phase because everybody has to do these type of occupations, but this is the last thing that comes back with a distal radius fracture and many, many other types of injuries. So they're doing a lot of work sim, a lot of torque. Here's a lady skinning a seat for a local Toyota plant, somebody working overhead, plyometrics, and this basic work sim. Also, postural stability is extremely important, like I mentioned, and we have to push postural stability subconscious. All of our exercises are conscious in nature, but the scapula works subconscious for it to be truly functional. Complications, we see these occur and surface after the acute inflammatory phase calms down. We see a lot of carpal tunnel irritations that can occur, and they start showing their ugly head at the 6 to 8 week point. We profile that. We put a severity index on it with the Sims-Weinstein and with other testing, manual muscle testing that's focal to the nerve, abductor pulsus brevis, carpal tunnel compression test. And then we send the data back to the surgeons, and they can sort it out as to how they want to manage it and maybe do an EMG. Dorsal plates, the gentleman mentioned earlier, the doc, these can pose a challenge, but the biggest thing, if we can control the edema early and fix the intrinsic tightness early, and then start thinking about when they do pull the plate, we can work on the extensor adhesions. But we put these people in early dynamic crane splints, and I'll show you an example one just in a moment. But we put these over top of casts or build them over top of the patient, and we move them right away. These crane splints are the same type of splints we use for replant hands and replant fingers. So they're very safe, but they actually promote and they feed the extrinsic flexors, which will actually pull the tendon across the plate so they don't get stuck, and the MCPs don't get stuck, and the extrinsic extensors don't get stuck. Then once the plate comes off, we work on carpal stiffness, and we have some splints that I'll show you to fix those. We always want to look for complex regional pain syndrome. I mentioned earlier we treat everybody like they have it, so they don't have it, but you can still inherit it. We know that there's 3 levels of pain, the cerebral level, the spinal cord level, and the peripheral level. And this comes from Wendell Merritt, and you got to figure out where it's coming from based upon the age of the injury and the type of symptoms that you see. But we commonly see vasomotor, pilomotor, pseudomotor, trophic changes, and we really work hard on trying to focus on catching this extremely early in the early phase. Now, a lot of people are going to have autonomic symptoms, but when they start having what I call jumpy joint pain and a glossy look, and if we're not treating that early, we're going to miss it. So I tell all my therapists, we treat everybody like they have it, so therefore we don't have it. Stage 1 are pretty easy to treat. Stage 2, very hard to turn. Stage 3 is almost impossible to turn. My preference is early recognition, no passive range of motion into a pain reflex. Don't feed the pain reflex. Active treatment on the edema, TENS on the median nerve, scapular stabilization, graded motor imagery, neuroglide, stress loading, functional activities. And because I own the place, I can treat people 2 to 3 hours per treatment, and they need that because they're afraid. Most people are afraid, and they need longer treatment sessions. Therapy will work, but your therapist have to see them for long periods of time to get the outcomes that you want to get out of your patients, particularly the ones that are projects. Remember that. They need more than an hour to get better. We also see a high number of osteoarthritis, particularly in the patients over the age of, in their 6th decade of life, and we treat that before we start doing loading activity. So I'll put a custom orthotic on a person that has CMC joint pain. When they fall and break their wrist, it awakens up a sleeping giant called CMC arthritis, and it becomes a big limiting factor when you start trying to strengthen. So treat the CMC arthritis with a simple splint so you can actually start strengthening and get these fingers moving, and so you don't have CRPS or other issues come up. There's also other wrist problems. We see TFCC injuries, fovea injuries, dorsal rims injuries. We see ECUs, FCU injuries, ulnar abutment problems we'll see as we start weight bearing and doing more and more higher level activities. And we see sometimes early, we start loading the system, we see some early ulnar nerve issues that can occur. Orthotics, mainly the key is it's the strongest weapon that we use to fix the complications that we have in the late stage, in the 8 to 10 week stage of rehab. And so our primary goal is to restore function and balance with a custom orthotic. And we only make custom orthotics. I come from the old school of thought. I've been around 35 years, and we make complex custom orthotics to fix problems. Here's a basic resting hand splint to control edema. Here's a intrinsic orthotic to actually lengthen the lumbrical through force, dorsal approach. And remember, if the lumbrical is loose, the profundus can work. If profundus works, you can make a fist, you can push swelling out, you can have gross motor and fine motor dexterity, and you can be functional. Again, we have splints that fix extrinsic tightness for both flexors and extensors. Here's an example of an orthotic, forearm-based, with a knuckle bender and finger flexor that pulls the fingers into flexion and composite fist, and then we pull the composite fist down into flexion, lengthening the extensor mechanism and lengthening the scar and tendons through the scar base at the dorsal of the wrist. It actually defeats the extrinsic tightness. If you don't defeat this, you're going to have scapular destabilization because the scapula is going to destabilize to do your activities. If you don't fix this problem, you're going to have scapular destabilization and impingement. Here's an example of an extrinsic flexor orthotic. We call this the dinosaur orthotic. It's got a volar approach, and then we actually put a plate on the fingers, and we lengthen the extrinsic flexors and the wrist flexors at the same time. Static progressive in nature, goes slow and static. The patients usually wear these splints at least 2 hours, 3 times a day to lengthen the tissue. When they're not wearing them, they're doing their exercise home program. And these people are going to be, we adjust these orthotics as needed and watch the pain reflex with them. Here's an example of MCP orthotic. We use a lot with dorsal span plates to actually fix the static progressive stress to fix the MCP joint and pull it down to a closed pack position, and also lengthen the extrinsic extensors. This would be like a stage 1 orthotic before we go back to this orthotic, because you get to stage these in place to fix your problems. There's a off-the-shelf dynamic wrist extension splint to maximize the grasp reflex. Oftentimes you'll see extrinsic tightness of just the wrist flexors, but not commonly. Normally, your digital flexors are the ones that get stuck, particularly your FPL. You got to be aware of the FPL. The FPL will get stuck because where's the plate going? Right where the FPL lives. So you got to be aware of that and think about that. Supination orthotics, simple is better in my situation. I've tried all the fancy supination orthotics, and we lose supination with distal radius fractures. Why? Because the forearm is in a open pack position and in pronation. So therefore, when you try to go into supination, it opens up and expands the interosseous membrane, which is along the axis of rotation here in the blue. So we use a real simple LMB type orthotic that we can lengthen and easily put on. The patients can put it on very easily, and we can slowly adapt the tissue over a long period of time. The biggest adaptation I do with this splint is I actually build a wrist gauntlet and put the gauntlet in place, so I have a longer lever arm for the length of the forearm, so I can put several areas to put force through the forearm as we're trying to regain supination. Here's a wrist gauntlet, leather gauntlet I make in the clinic. Probably one of the few therapists in the country that make leather gauntlets. I can make these orthotics in about 20, 30 minutes, but they're great for wrist arthritis and great for PRCs. The patients need a little extra support. Circumferential leather orthotics work extremely well to control pain. It's a great profile and pedestal to do higher level strengthening and higher level functional activities on. Last but not least, I'll show you the crane splint. This is a splint that I've been using for the last 30 years. We can put it over top of cast. This situation, this gentleman came in. He was a little over 6 weeks post distal radius fracture. Could not move his hand because he had lost his feedback loop. And you can see the splint go here. And the splint actually feeds the extrinsic flexors. The tension stays constant through the full arc of motion, and it works extremely well. We use this on, like I said, on replant hands, on replant fingers. It works extremely well. It's easy to use. We even use it on zone 5 and zone 4 and zone 3 flexor tendons at 10 to 12 days. And so it's a very safe orthotic because you can control the gram force on it. So you're not going to hurt the fracture, but you're going to feed the extrinsic flexors to maximize your outcome, pump the edema out, and overall get a good functional outcome. Last but not least, discharge criteria. We shoot for 90% of range of motion, 80% of strength, 90 to 100% of upper extremity dexterity through gross motor, fine motor. We shoot for a dash less than 20 and a global rating of change greater than 4. Thank you for your time. I appreciate the opportunity.
Okay, thank you very much, Greg. That was a great comprehensive approach to the rehabilitation, especially including the scapula and the close kinetic change involved in this. Abigail or Mackenzie, how much do we time have left on this webinar? If you have time, I'd like to put some cases. Okay, I'm gonna share my screen.
Yep, I think that's fine. We can go a little bit longer.
Thank you. All right, so I'll ask our other faculty to come out on the video so that I can kind of involve them into this case I'm going to present. Can you see my talk? Okay.
Looks good.
Excellent. So I'm going to bring a case here. Is a 53-year-old right-hand dominant female who fell in camping with the left distal intraarticular distal radius fracture. She's healthy, but extremely obese. She's more than 60 BMI, lives alone. So she has to use her hand, that she's the only one. She doesn't have any help around the house. She's recently divorced. So, and here is the picture of the fracture. You see the size of the arm is from the soft tissue. It's very deep. And so I'll ask either Brett or Neil if you want to give a crack of what do you think our aim should be and how we will approach it. Would you try to close reduction? Would you just go ahead with an open reduction right off the bat?
I'll give it a shot. Obviously, if this is in the ER, this needs a closed reduction. It's displaced enough that you could be at risk of developing carpal tunnel syndrome, and you want to get the soft tissues unloaded, at least to allow for her to begin some finger motion while in the splint. Because if you look at this pattern of fracture, the amount of shortening, the fact that it's a shearing injury, it looks like with multiple volar fragments, this is going to be one you're going to treat operatively. So we more than likely are not going to get her into surgery within 48 hours or sometimes within a week. So a reduction and good positioning to allow for good finger motion is the first step.
Good thing you brought up. So that's what we did. Here is the attempted reduction in sugar tongue splint with traction.
Yeah, and after that, I would ask to get a CT scan, and I would get 3-dimensional reconstructions to kind of assist my planning.
Well, that's what it is. We have our CT scan. Brent, now you see this fracture here. Actually, one of the questions that came up in one of the question and answer session is, when do you decide to go volar, when do you decide to go dorsal?
So, I mean, I normally try to go volar and bail out dorsal. If I can't get everything where I want and try to buttress it up volar. But on this case, I think I would go dorsal first and use my spanning plate as an internal X fix, and then flip around and probably try to take care of the articular surface on the volar side, and use it more as a buttress. At least just looking at this, I would probably do it that way.
Okay. Well, this is my own case.
Yeah.
I thought I'll give it a shot going volar first. If I can put it together, and if it's good enough, I would call it today. So
Yep.
that's what I did. I went volar. I
Fantastic.
did look at the CT scan, and as we go back, as Dr. Harness brought it up, the volar ulnar corner was separate. There was a small fragment. It was only 6-7 millimeters. So I specifically got this this plate because it had that special. Oh, sorry. Let's go back. Special hook that would capture that volar ulnar corner. And so this is what this is. Patient came back after 2 weeks, and we had the splint off. Yeah, of course, knowing that she's alone at home and she's going to use the arm, it's something in retrospectoscope you can tell, because when she came back after 6 weeks, now this was the story. Obviously, when you have a very heavy person using the arm, that little screw has no chance of doing anything. So, what do you think, Brent? What's going on?
Yeah, you lost your fixation on the radial side. It looks like your ulnar side's okay. Again, you could either try to do spanning, or you're going to probably have to get that one screw out that's heading towards your scaphoid.
Yeah, interesting enough, she comes in, she's just happy as a clam. She doesn't have any pain. And
Yeah.
she's like, okay, thank you, doctor, for fixing my wrist. So I got a CT scan to
Right.
see what's going on. And as you can see, Neil can kind of go over this because he just talked about it.
Yeah. Obviously I see the hook on the top left. I can't remember if does this one have a rotational issue, like the hook rotated on the screw? Yeah. So this is a known problem with this plate, and I think they've tried to fix this, but the screw is very short, and you're really relying on a friction fit to hold that little hook in place, and it can just spin right around that axis. And so I've had one of my own, and I've seen several online, and this one is another example that rotates.
There's 3D.
Yeah. So the screw will act like a pivot point, and the lunate facet just spins it right around it. And then I agree with Brent. I thought the radial styloid also looked like it had lost fixation, and this might be one where, perhaps a radial column plate with some bone grafting might have been appropriate at the first stage. But ultimately, spanning it with a spanning plate may have neutralized the forces enough that this might not have happened. It might have still happened. It's possible.
So, Greg, if you have this person coming 2 weeks down to you, and what kind of a therapy are you going to do without disturbing the fracture?
We can start digital motion, I would think, right away. Edema control we usually use a digigauze. If the particular person only has one hand, we use digigauze initially for edema control. The fingers, get them moving. TENS unit, usually go underneath the cast if you got a cast on, or if you got a splint. If you make a splint, I would make a circumferential splint, or I'd make a gauntlet and put a heavy leather on the back to give you a buttress, to give you a circumferential buttress around the so she doesn't migrate out of the orthotic.
So, well, we have this, and so I talked to her and I said, look, things are not looking good, and in order to get you better, we need to fix this, especially the reduction. So the question is, do we do ORIF? Do we do wrist fusion? Do we do arthroplasty? Of course, she's very heavy, and I don't think any of the arthroplasty would have any chance of working. Fusion she didn't like because she was alone and she wanted to use it. So we went to for the ORIF. So here's what we did. We used a spanning plate to kind of take the tension off this, and used a volar plate plus this ulnar hook plate to capture that volar ulnar corner. And then we also had a radial column plate to hold the radial side, because amazingly, usually we think heavy persons don't have osteoporosis, but her bone was not very good trying to hold things. So, and she did okay. This is after about a year down the road, after removal of the plate, and you got the CT scan just to make sure the screws are not into the joint, and there weren't. and she had a little occasional pain, but otherwise pretty happy, and so we left it at that.
Great.
We had some questions I need to bring up for answering. Basically, one of the main questions is, how do you decide to go volar or dorsal? I'll take any of to answer it first.
Oh, I mean, I think it largely depends on the fracture pattern. If you are dealing with a isolated dorsal shearing fracture, I think those are the ones where you're absolutely going to go dorsal. There's no way to really gain adequate fixation through a volar approach. I think that multifragmentary intraarticular fractures may require a combined approach, but I don't think with having volar plates available and how good they are, that I would isolate my approach to just a dorsal approach. So there's very few I think that would only go dorsal. In other words.
And there was one other question specifically for Dr. Harness. They were asking what is that wire fixation that you brought up for the volar honor corner?
Right. It's a published technique. I'll be honest, I can't remember when it came out, but it's within the last 10 or 12 years. But basically, you take a couple 4 or 5 K wires, you put your K wires into the fragment, and then you bend the K wires down so that they're now flush, almost like a 90-degree angle, flush to the volar cortex of the radius, and then you place your volar plate on top of the wires, essentially capturing the wires under the plate. And it's I think they term it a spring construct. You obviously have contact between two different metals. If you use a titanium plate and K wires, that could be an issue. I prefer, instead of doing that, just same K wires, but now just feed a couple headless screws down over those, and that has worked in my hands pretty well.
And then Brent, with one other question, when do you recommend removing spanning plates?
3 months. So I wait for 3 months right now. I have changed that rule when I've got other fixation in, and don't make it hard and fast, but I've maintained it at 3 months. Is when
do you manipulate the wrist after removing the plate?
I'm sorry, I missed it.
Do you manipulate the wrist?
No. It's surprisingly I haven't had to do that. The therapists get it moving. I don't know why, but the same thing as X fixes for a period of time. We had X fixes on for 8 weeks, then it was 10 weeks, and it was 12, and the range of motion comes back. But I think again, the talk from our therapist is that if you get digital motion going and they're functional, the wrist will come and follow afterwards. If you don't have digital motion, then I think you are going to have problems with that wrist. So that's why it's so important to me to get your help with a therapist to get full supination, pronation, and a good fist. One other comment, and I'm sorry to steal this a little bit, but those dorsal shears, there's been a lot of talk about the dorsal Bartons don't really exist. For the point being is they're really fracture dislocations, because to get a dorsal Bartons, you would have to rupture all the volar ligaments. So it's a higher energy injury. And that is one that I look at. And there are sometimes smaller fragments. So that's one that I go dorsal. And as I said, to the third metacarpal, trying to fix those fragments. But just the buttress of the dorsal doesn't make as much sense to me, because I'm not sure how you rupture those volar ligaments versus the other way around. So volar Bartons, we know, is a buttress problem. So talking about going volar and dorsal.
Well, thank you very much. We are coming to the end of our talk on the distal radius fracture webinar. It's about 27 after the hour. We're kind of about 10 minutes over what we were allowed. I appreciate all of you, especially Dr. Pitts, Bamberger, and Harness, and McKinsey, and Abby, to help this happen. It was a beautiful, great talk from all the faculty. And don't remember to check out our other AO webinar coming up, especially end of this month and in August and September. And have a good day. Thank you very much.
Thank you.